Pregnancy and breast cancer. Green Top Guideline number 12, March 2011. Purpose and scope. The management of pregnancy in relation to breast cancer is multidisciplinary. Background. Breast cancer is the most common cancer in females, with a lifetime risk of 1 in 9 in the UK, and is the leading cause of death in women aged 35 to 54 years. 15% of cases are diagnosed before the age of 45 years. The prognosis of breast cancer is improving, with 5-year survival around 80% for the under 50s age group. However, the survival rate may be lower in very young women. Treatment of pregnancy-associated cancer should be in a multidisciplinary team with inclusion of the obstetric team as core members. Fewer than 10% of women diagnosed with breast cancer subsequently become pregnant, but increasing numbers of women are seeking pregnancy following treatment. Young women presenting with breast cancer often have fertility-related concerns and need well-informed discussions on fertility, pregnancy, and lactation after breast cancer and the availability of fertility preservation procedures. What is the optimal management of breast cancer diagnosed during pregnancy? Prognosis. Pregnancy itself does not appear to worsen the prognosis for women diagnosed in pregnancy compared with non-pregnant controls matched for age and stage. However, as pregnancy-associated breast cancer occurs in younger population who may have features that carry a higher risk of metastasis, such as high-grade tumors and estrogen receptor negative tumors, these younger women may be expected to have an inferior prognosis. Diagnosis. Women presenting with a breast lump during pregnancy should be referred to a breast specialist team, and any imaging or further tests should be conducted in conjunction with the multidisciplinary team. Diagnosis may be difficult in women who are pregnant or lactating. Women should have a designated key worker, usually a breast care nurse. Ultrasound is used first to assess a discrete lump, but if cancer is confirmed, mammography is necessary with fetal shielding to assess the extent of disease and the contralateral breast. Tissue diagnosis is with ultrasound-guided biopsy for histology rather than cytology, as proliferative change during pregnancy renders cytology inconclusive in many women. Histology is similar to that in age-matched non-pregnant counterparts, histological grade, receptor status, and human epidermal growth factor receptor 2 or HER2 Inform treatment planning. Staging for metastasis is conducted only if there is a high clinical suspicion and should comprise chest X-ray and liver ultrasound if possible. Gadolinium-enhanced magnetic resonance imaging is not recommended unless there is a specific need for it to investigate a clinical problem. Tumor markers such as CA153, CEA, and CA125 are not used in early breast cancer and may be misleading in pregnancy and are not recommended. Bone scanning and pelvic X-ray computed tomography are not recommended because of the possible effect of irradiation on the fetus. In women who are not pregnant, X-ray computed tomography or CT and isotope bone scan are the preferred methods of investigation to establish or exclude metastasis. These methods are not appropriate in women who are pregnant, in whom chest X-ray and liver ultrasound are preferred. If there is concern about bone involvement, a plain film of the relevant area and/or magnetic resonance imaging to minimize radiation exposure to the fetus is suggested. Consideration of termination of pregnancy. The decision to continue the pregnancy should be based on careful discussion of the cancer prognosis, treatment, and future fertility with the woman and her partner and the multidisciplinary team. Treatment during pregnancy. The multidisciplinary team review outcome should be forwarded to the obstetric team and family doctor. Surgical treatment, including loco-regional clearance, can be undertaken in all trimesters. Breast-conserving surgery or mastectomy can be considered based on tumor characteristics and breast size following multidisciplinary team discussion. Reconstruction should be delayed to avoid prolonged anesthesia and to allow optimal symmetrization of the breasts after delivery. Sentinel node assessment using radioisotope scintigraphy does not cause significant uterine radiation, but blue dye is not recommended as the effect upon the fetus is unknown. Sentinel node biopsy is indicated in women who have a negative result from a preoperative axillary ultrasound and needle biopsy. If the axilla is positive, axillary clearance is indicated. Radiotherapy is contraindicated until delivery unless it is life-saving or to preserve organ function, for example, spinal cord compression. If necessary, radiotherapy can be considered with fetal shielding or, depending on gestational age, early elective delivery could be discussed. Routine breast or chest wall radiotherapy can be deferred until after delivery. Systemic chemotherapy is contraindicated in the first trimester because of a high rate of fetal abnormality, but it is safe from the second trimester and should be offered according to protocols defined by the risk of breast cancer relapse and mortality. Anthracycline regimens are safe. There are fewer data on taxanes, which should be reserved for high risk or node positive or metastatic disease. Standard antiemetics, including 5-HT3 serotonin antagonists and dexamethasone, should be used. There is no evidence for an increased rate of second trimester miscarriage or fetal growth restriction, organ dysfunction, or long-term adverse outcome with the use of chemotherapy. For women in whom tumor characteristics, defined by imaging and core biopsy, mean that chemotherapy is indicated, a decision may be made to offer neoadjuvant chemotherapy before surgery to allow tumor downstaging and to facilitate surgery. Occasionally, with a low-risk tumor in which chemotherapy is not indicated, there may be an indication for mastectomy. In this situation, radiotherapy would be deferred. Tamoxifen and trastuzumab are contraindicated in pregnancy and should not be used. Tamoxifen is not used until after delivery. Trastuzumab, a monoclonal antibody targeted against the human epidermal growth factor receptor 2 or NER receptor, is contraindicated during pregnancy because of reported adverse fetal outcome. There are no compelling oncological reasons for use of targeted therapies, including monoclonal antibodies or small molecule tyrosine kinase inhibitors during pregnancy, as conventional chemotherapy can be used, allowing these drugs to be reserved for postpartum. Hemopoietic growth factors such as granulocyte colony stimulating factor may be employed to ameliorate chemotherapy-induced neutropenia and have been used extensively in hematological malignancy. Their use is recommended to minimize potential maternal and fetal problems associated with neutropenia. Use of this and other drugs should be discussed with the obstetrician. Timing of delivery of the baby. The birth of the baby should be timed after discussion with the woman and the multidisciplinary team. Most women can go to full term of pregnancy and have a normal or induced delivery. If early delivery of the baby is necessary, consideration of corticosteroids for fetal lung maturation is appropriate. However, birth should be more than 2 to 3 weeks after the last chemotherapy session to allow maternal bone marrow recovery and to minimize problems with neutropenia. Lactation. Women should not breastfeed when taking trastuzumab or tamoxifen, as it is unknown whether these drugs are transmitted in breast milk. The ability to breastfeed may depend on surgery and whether major ducts have been excised. Breastfeeding while on chemotherapy is not advised, as the drugs cross into breast milk and may cause neonatal leukopenia with a risk of infection. There should be a time interval of 14 days or more from the last chemotherapy session to start of breastfeeding to allow drug clearance from breast milk. If chemotherapy is restarted, breastfeeding must cease. A short period of lactation may be psychologically beneficial after a stressful pregnancy and be beneficial to the baby. Women taking tamoxifen should not breastfeed. What are the contraceptive choices for women wishing to avoid pregnancy after treatment of breast cancer? Non-hormonal contraceptive methods are recommended. Women with a history of breast cancer should seek specialist contraceptive advice. Hormonal contraception is contraindicated in women with current or recent breast cancer or the UK Medical Eligibility Category 4. This advice does not differentiate between hormone-sensitive and hormone-insensitive tumors. Although hormonal contraception may be considered after at least 5 years free of recurrence, and current evidence allays concerns that long-term oral contraceptive use affects breast cancer risk. The levonorgestrel intrauterine system may reduce the risk of endometrial abnormalities during tamoxifen therapy, but further evidence is required on its safety in breast cancer survivors. What advice should be given to women planning pregnancy following breast cancer? Women planning a pregnancy after treatment for breast cancer should consult their clinical oncologist, breast surgeon, and obstetrician. Women on tamoxifen are advised to stop this treatment 3 months before trying to conceive because of the long half-life of the drug, and to have any routine imaging before trying to conceive to avoid the need for imaging during pregnancy. Women with metastatic disease should be advised against a further pregnancy as life expectancy is limited and treatment of metastatic disease would be compromised. Impact of pregnancy on risk of recurrence. Women can be reassured that long-term survival after breast cancer is not adversely affected by pregnancy. Since many breast cancers are estrogen receptor positive and endocrine responsive, women used to be advised against pregnancy because of concerns that it would worsen prognosis. The prognosis is good for women with a subsequent pregnancy after early-stage breast cancer. The healthy mother effect is described as the healthy women are more likely to conceive, and women with poor prognosis or early relapse do not embark upon pregnancy. The impact of pregnancy does not seem to be modified by tumor characteristics, for example, size, hormone receptor status, but there are insufficient data to draw firm conclusions. In women with breast cancer gene mutations, the risk associated with subsequent pregnancy are uncertain. Time interval before pregnancy. Advice on postponement of pregnancy should be individualized and based on treatment needs and prognosis over time. Most women should wait at least 2 years after treatment, which is when the risk of cancer recurrence is highest. Women are generally advised to wait for at least 2 years after treatment for breast cancer before conception because of the risk of early relapse. The rate of disease recurrence is highest in the first 3 years after diagnosis and then declines, although late relapses do occur up to 10 years and more from diagnosis. Women with estrogen receptor positive disease should be advised that the recommended duration of tamoxifen treatment is 5 years. It has been suggested that women with good prognosis need not wait 2 years to become pregnant. An understanding of the prognostic factors affecting the individual woman tumor size, grade and nodal status, estrogen and progesterone receptor, and human epidermal growth factor receptor 2 status should enable the oncologist to give appropriate advice. This of great importance to the woman desiring pregnancy who may need to weigh up the benefit of postponing conception, for example, to complete prolonged adjuvant therapy with tamoxifen against the risk of infertility as a result of delay. Outcome of pregnancy. The majority of pregnancies after breast cancer proceed to live birth. Women are more likely to terminate a pregnancy when it occurs soon after treatment or during adjuvant therapy. Women can be reassured concerning the risk of malformation in children conceived after treatment for breast cancer. Most of the available data do not show any increase in congenital malformations or stillbirth among the offspring of women who have completed treatment for breast cancer. The heritability of breast cancer is a source of anxiety but does not affect childhood health. Women who are known to be breast cancer gene carriers may wish to consider pre-implantation genetic diagnosis. What is the optimal management of pregnancy following treatment for breast cancer? Pregnancy following breast cancer should be jointly supervised by the obstetrician, oncologist, and breast surgeon. Echocardiography should be performed during pregnancy in women at risk to detect cardiomyopathy through resting left ventricular ejection fraction or echocardiographic fractional shortening. During pregnancy, a breast treated by surgery or radiotherapy may not undergo hormonal change, and the woman may require a temporary prosthesis. If breast imaging is needed, ultrasound performed through the breast multidisciplinary team is preferred. Metastatic relapse may be harder to detect, and common complaints in pregnancy, such as backache, can be difficult to assess. These women may have received adjuvant chemotherapy with anthracyclines such as doxorubicin and epirubicin, which can cause cumulative dose-dependent left ventricular dysfunction and rarely cardiomyopathy. A slightly increased risk of delivery complications and cesarean section has been reported in breast cancer survivors. The supervision of pregnancy after breast cancer should be consultant-led, but midwifery involvement will help to normalize care. What advice should be given to women wishing to breastfeed following treatment for breast cancer? Women can be reassured that they can breastfeed from the unaffected breast. There is no evidence that breastfeeding increases the risk of recurrence in women who have completed treatment for breast cancer. Breast-conserving surgery may not inhibit lactation in the affected breast, but radiotherapy causes fibrosis, making lactation unlikely. There is no evidence that previous chemotherapy affects the safety of breastfeeding. In view of the well-recognized benefits of breastfeeding to the baby, women who wish to breastfeed should be encouraged to do so. Midwifery supports helps to establish successful lactation. What is the effect of breast cancer treatment on the woman's fertility? The effect of treatment on fertility should be discussed with all women of reproductive age diagnosed with breast cancer, and written information should be provided. Referral to a fertility specialist should be available. Specialist counseling should be available. Infertility after treatment is a major concern for young women with breast cancer. Women's preferred source of information on fertility is consultation with a fertility specialist, backed up by an information booklet. A recent joint working party of the Royal Colleges of Physicians, radiologists and obstetricians, and gynecologists in the UK recommended that people with cancer should be fully informed of potential gonadotoxicity before treatment, and that specialist psychological support and counseling should be available. What is the effect of adjuvant chemotherapy on fertility? Chemotherapy-induced gonadotoxicity may cause permanent amenorrhea with complete loss of germ cells, transient amenorrhea, menstrual irregularity, and subfertility. The degree of gonadotoxicity is dependent on the specific agents used, the cumulative dose administered, and the woman's age. Amenorrhea is reported in 20 to 70% of premenopausal women with breast cancer, but the rate ranges from less than 5% in women under 30 years of age to 50% in women aged 36 to 40 years. Alkylating agents such as cyclophosphamide have well-recognized gonadotoxicity, and the classic CMF regimen or the cyclophosphamide methotrexate 5-fluorouracil causes a higher incidence of amenorrhea than anthracycline-based regimens such as FEC or the 5-fluorouracil, epirubicin, and cyclophosphamide. The newer taxanes appear to be less gonadotoxic. What is the effect of adjuvant hormonal therapy on fertility? The agents used for adjuvant hormonal therapy do not in themselves cause long-term effects on fertility. Tamoxifen, a selective estrogen receptor modulator, often causes menstrual irregularity, and there is an increased risk of endometrial pathology. Conception during tamoxifen therapy should be avoided because of potential teratogenicity, and a washout period of 2 to 3 months is advised. Gonadotrophin-releasing hormone analogs cause amenorrhea and profound estrogen deficiency. Women may find the menopausal symptoms worrying, but the effect is entirely reversible. Trastuzumab is a monoclonal antibody that binds selectively to the human epidermal growth factor receptor 2 protein expressed by some breast cancers. There is no evidence that it impairs fertility, but pregnancy is not advised during treatment. What advice should be given to the women about postponement of pregnancy before embarking on further pregnancy? Women are generally advised to postpone pregnancy for at least 2 years after treatment and may be advised to continue tamoxifen for 5 years. However, age is a major determinant of fertility, and delay with already poor ovarian function owing to chemotherapy is likely to lead to infertility. Women in their 30s desiring pregnancy may wish to discuss the value of prolonged treatment with tamoxifen and consider discontinuation after 2 to 3 years. Can fertility be preserved before treatment? At present, only a minority of women of reproductive age undertake fertility preservation procedures, and there are scarcely any data on long-term outcome. Gonadotrophin-releasing hormone analogs. There are insufficient level 1 data to support the routine use of gonadotrophin-releasing hormone analogs for ovarian protection in estrogen receptor-positive breast cancer. Gonadotrophin-releasing hormone analogs have therapeutic use in hormone-sensitive breast cancer as they induce profound ovarian suppression and create a low estrogen state. A recently reported randomized controlled trial in premenopausal women with breast cancer found that co-treatment with gonadotrophin-releasing hormone analogs during chemotherapy lessened the risk of ovarian damage. Cryopreservation. Ovarian stimulation for egg or embryo freezing requires careful discussion in light of a known long-term risk. Modified stimulation regimes should be considered for women with estrogen-sensitive breast cancer. Embryo cryopreservation is a well-established technique with success rates of at least 20% per cycle, although it is possible that success rates may be lower when oocytes are retrieved from women with cancer. The time required for ovarian stimulation and egg harvest may postpone chemotherapy, and there is a small risk of procedural complications such as ovarian hyperstimulation. There is concern that elevated estrogen levels may be deleterious in estrogen receptor positive breast cancer. To minimize this risk, stimulation regimens with tamoxifen or letrozole, usually combined with gonadotropins, are proposed. Oocyte storage may be offered to women without a partner. Freeze-thaw techniques are rapidly improving, but there have been only a few hundred births worldwide after use of this technique, and there are no long-term safety data. There are insufficient data to support ovarian tissue storage for fertility preservation in women with breast cancer. This should be offered only in the context of a research trial. Cryopreservation of ovarian cortex, or the whole ovary, has resulted in a small number of pregnancies after regrafting. This remains an experimental technique, and tissue storage regulations in the UK have restricted its use. The need for surgical procedure is a disadvantage, but this technique does not delay chemotherapy. Every breast oncology service should have a designated pathway for prompt referral to a fertility specialist able to offer assisted conception. Service provision should not be dependent on local in vitro fertilization funding arrangements. The National Institute for Health and Clinical Excellence recommended universal access to sperm, egg, and embryo storage for people undergoing gonadotoxic treatment. Assisted reproduction after treatment for breast cancer. Fertility treatment after chemotherapy is limited by loss of ovarian reserve. The stimulation aspect of in vitro fertilization carries a theoretical risk as it is a hyperestrogenic state, although of shorter duration than pregnancy. Women who have chemotherapy-induced menopause can become pregnant with donated eggs. This requires short-term hormone replacement therapy, which again carries a theoretical risk. Replacement of cryopreserved embryos is also performed in a medicated hormone replacement therapy cycle. Women for whom pregnancy is contraindicated may wish to consider surrogacy.